Good morning. I'm Dr. Joy from Amla Institute of Medical Sciences, Trichy, and I'll be talking to you about WBC changes in health and disease. Now, this is the brief overview of the lecture. The introduction would carry the features regarding the smears, the artifacts, the normal cells. Then, of course, we have the quantitative alterations of leukocytes, which is becoming increasingly important nowadays, more than the morphology. Then we have the WBC changes in infections, which are specific and which are non-specific. And then we'll be talking briefly about the qualitative disorders of leukocytes, which are very rare in the first place. And finally, we'll be talking about neoplastic diseases. Neoplastic disease, I will not be talking to you about specifics, but I will be talking to you about the general features of conditions. The first of all, we'll go to two rules of reporting a blood smear. Now, blood cell changes in any cell line should not be interpreted in isolation. Should be with the clinical scenario only. This is very, very important. Then blood smear report should be signed out only after thoroughly studying the hemogram, because the hemogram will give you certain clues which you may not have seen in the first place, may make you look at the smear once more. So these 2 points are very, very important. Now, regarding the blood smear preparation, smears have to be prepared within 15 minutes is the best time, 15 to 20 minutes. Up to 2 hours, you'll find some changes are happening. If it's more than 5 hours old, you will find serious artifacts like autolytic changes, as you can see here, and you can see the cytoplasmic changes here. And also sometimes the nuclear changes may look like pelgeroid neutrophils. So this is very important. So if you are actually examining a smear made 5 hours or later from stored blood, you can find all types of changes which can mislead you. Now, some of the other things which can be seriously misleading is this pseudo-hairy cells. Pseudo-hairy cells are very important because an enthusiastic pathologist, especially a fresh person, may report this as hairy cells and interpret it as such. So you have to be very careful about this point. The thing that you're expected to see is the eosinophilia of the cytoplasm, which is very often evident, and especially in the periphery. The next thing is regarding the extraneous cells that creep into the blood smears. Squamous cells can come if you are actually handling the slide before you make a smear, and this can be sometimes quite numerous. This actually is because of the technical impropriety of the technician. Now, endothelial cells can creep in even with the best of technicians, best smear preparations. And this is because, and especially so when you make a bone marrow smear and if you find such cells, it can seriously make you think twice. So you have to be very careful about the existence of these type of cells. Now, how should normal cells look like? Now we look at the normal cells based on the size, the cytoplasm, and the nucleus. The lymphocyte is the simplest of cells with a round nucleus and a very scanty rim of cytoplasm. While the monocyte is the largest cell and its nucleus can be anywhere from kidney-shaped to figure-of-8 shaped or twisted. So the figure-of-8 or the kidney-shaped is not always a rule. Next, the cells with the cytoplasm which you look at. The eosinophils stand out because of their orangeophilic granules, basophils with the basophilic granules, and the neutrophils may not show the granules properly but will have a violetish tinge. Of course, the neutrophils will be multilobulated. Now, this is a slide which is to tell you something about the granulocytes. Now, you can see the myeloblast to the mature granulocyte in the normal marrow and blood smear. Generally, you don't find these cells which are above this line in the peripheral blood smear, but metamyelocytes do occur sometimes in reactive states. Now, this is the thing. Nucleus, you look at the changes in the nucleus shape. Now, the cells which are in the marrow are capable of mitosis, while metamyelocyte onwards, mitosis is not possible. Now, we look at the mononuclear cells. This is quite a different thing altogether. Mononuclear cells, you find normal lymphocytes and normal monocytes in the bone marrow and the peripheral blood. You generally do not find lymphoblasts or monoblasts in the marrow or in the peripheral blood for that matter. You never see them. So this is the thing. Monoblasts may not be recognized in the marrow because it may look like myeloblasts. But you generally don't find immature forms of these cells normally except in neoplastic states. Now, regarding the lymphocytes, some lymphocytes are capable of mitosis. Please do remember this point. Because reactive lymphocytes, especially in certain viral infections like mononucleosis, you'll find that reactive lymphocytes in the peripheral smear do show mitosis. Because they are the only cells which are close to having the mitotic activity retained or generated late because of the reaction. Now, what are the quantitative alterations in leukocytes? Now, this is increasingly important nowadays. We'll come to that as we go along. Now, neutropenia is an leukemia reaction well known. Neutropenia is also well known. Eosinophilia is also well known. Eosinopenia is generally not a recognized thing, primarily because the eosinophils are very small in number. So eosinophilia is recognized, but eosinopenia is generally not recognized. Now the same thing applies to lymphocytopenia. Lymphocytopenia is generally not recognized because the percentage of lymphocytes are very small in the, say, 30%. And neutrophils predominate in the peripheral blood smear. So this is also has to be recognized. Lymphocytosis, etc., monocytosis, they can be easily recognized. One thing to remember is that the causes of both leukocytosis and leukopenia are many and may be the same. So leukopenia and leukocytosis may be caused by the same reason. This is one point you have to remember. Now, what is leukopenia? We won't go into the definition, it's written here. Neutropenia, less than 1,500. And below 500 per cubic millimeter is very bad. And generally, patients with such a count develop fungal septicemias. Lymphocytopenia. This is very, very important. Lymphocytopenia is very important nowadays. Eosinopenia also is becoming very important. Now, this is recognizable now because of the 5-part, 6-part, and 7-part cell analysis, which will actually show these things out. While if conventional blood smears, generally we don't see them. We actually think that it could well be because of the neutrophilia that you have less lymphocytes. So this point has to be noted. Several recent articles saying that eosinopenia can become a helpful tool, especially in neonatal septicemias. Now, leukocytosis is common, may show leukopenia, that's also important. Now, other points, remember, is artifacts may mimic morphological changes of infection. Toxic granulation and evacuation are very, very commonly seen in stored blood smears. So this is very important to remember. Now look at the sequence of events. This is becoming increasingly important. In several articles you will see this. Neutrophilia, monocytosis, mild eosinophilia. This is a very good sequence. This means that the patient is likely to do well. But if you find neutrophilia, then neutropenia, monocytosis, and eosinopenia, this is not a good sign at all. It means that the patient is going from bad to worse. So this is a sequence which we all should understand and remember. And actually, the clinicians should also be conscious of this. Now, neutrophil to lymphocyte ratio, or NLCR, NLR, is becoming increasingly important. Especially, this is important to predict sepsis in children. Now, in the recent COVID situation, this NLR was used to actually triage patients who are likely to do badly. Because several studies showed that when the NLR is high, you'll find that the patients do badly. So this is one of the things that so lymphocytopenia is a bad thing in a COVID patient. Pancytopenia refers to all the cell lines being decreased, and many of the disorders that causes pancytopenia also can cause bicytopenia. So this is important to remember. and may be associated with a multitude of disease states which can be life-threatening. What it means is that this slide will tell you the gist of it. Individual cell counts are becoming increasingly important in sepsis management and identification. This point has to go down. Now, what are the changes in infections? Morphological changes in the cells are generally non-specific. But if you actually find the infectious agents inside the leukocytes, then it's specific. We don't have any differential diagnosis. Now, this is one important change that you can see: toxic granulation, dolly bodies, Hubble dolly-like bodies, neutrophilic inclusions, bilirubin crystals, malarial pigment, melanin pigment. These are some of the things that you can see, but not very specific. Now, these are vacuolation. Please do remember that toxic vacuolation can resemble vacuolation due to artifact. Now, what are these toxic granules? Cellular stimulation of young neutrophils causes the membrane alteration, which causes the granules to appear larger and darker than normal toxic and normal, and that is, they are known as toxic granules. They are said to represent the primary granules. Now, what are these dolly bodies? Dolly bodies are small, round, oval, pale blue-gray structures about 1 to 2 microns in diameter, found in the periphery of the neutrophil. They consist of ribosomes and endoplasmic reticulum. This was first described in a patient with scarlet fever. Now, these are the other conditions that you can get this. Please remember that administration of a colony-stimulating factor can produce this change in the neutrophils. Now, when you find fragments of nucleus in the cytoplasm, this is generally called a dysplastic change, just like Howell Jolly body. And this is a feature which you generally associate with HIV-associated dysplasia. Myelodysplasia can be induced by HIV, and this is one of the manifestations in the peripheral blood. And this is considered to be one thing. It doesn't occur in other forms of myelodysplasia. So, neutrophilic fragments in the cytoplasm generally means that you have to check out the patient for HIV. Now, critical green inclusions. Now, these have been increasingly recognized and ignored. And they are actually bluish green bodies seen in the neutrophils and monocytes. And they are supposed to be a feature which you associate with terminally ill patients. And that is, terminally ill patients or ill patients who are likely to do badly. So this is a very bad sign, supposed to be, which is why it's called critical green inclusions. Now, there are several papers coming out saying that this has got to be not to be ignored, but has to be acknowledged and reported. With liver injury, this is one of the things which you see in a patient with hepatocellular failure. The presence of these inclusions generally herald onset of death. Now, bilirubin inclusions may be seen in hyperbilirubinemia, especially in neonates. Now, this is an article which came in Blood. And the bilirubin crystals are seen in patients with septicemia rather than with hemolytic disease. Now, this is an important point, so much so that this may be a feature which points to sepsis or severe sepsis. And the other point to remember is that this is not a phenomena which occurs in a direct blood smear. It occurs only in EDTA, samples collected in EDTA. So this is an important point to remember. So this may be useful. Now, malarial pigment in neutrophils is well known in falciparum malaria. So there's nothing improper. You can see lots of malarial parasite in the RBCs, and you find malarial pigment. Now, the point to remember is that when you find no malarial parasites and malarial pigment in the neutrophils, you've got to be very conscious that the patient may be having falciparum malaria. So this point is very, very important. Alterations in monocytes. Now, one thing which we did not mention about the neutrophils is that the neutrophil size also increases. Now, this is very important. Now, the same thing, monocytes also, one thing which is noticed in sepsis is that the size of the cells increase. So much so that certain counters, cell counters, analyze the hematology analysis actually measure this, and it's actually put as neutrophil distribution width and monocyte distribution width, NDW and MDW, and this is considered to be a pointer to sepsis. And I think some of the analysis it is already validated and available. Then you find vacillation, hemophagocytosis, and sometimes organisms. Now, if you find a cell like this in the peripheral blood smear, this is basically a histiocyte with all ingested platelets and RBCs. This is generally a feature which you associate with two conditions. One is hemophagocytic syndromes and in severe sepsis. Now, reactive atypical lymphocytes. Now, they are the cells which are very, very ubiquitous, and very often when you find cells which you can't actually put a name or label on it, it's actually called atypical lymphocytes. Of course, sometimes they are atypical lymphocytes, sometimes they may not be. And these are some of the things that you can see: molding and skirting of the cytoplasm. Skirting means actually you find that intensity of staining is increased in the periphery. The same thing here. So this is a molding. But this can also be seen in abnormal cells. Even blast cells or lymphoma cells can show the same thing. So this is it's important to realize that these cells are generally not seen in isolation. There are different types of atypical lymphocytes. Generally, all of them will be seen. But if you find only one type of cell like this, then you have to be careful, because then it could mean something else. Now, what are the leukocyte inclusions in infectious disease? You can find the actual organisms inside. Anaplasma, Ehrlichia, these are not, the ones marked in red, you are unlikely to come across. Cryptococcus, you may. Toxoplasma, you may. But the others are not. This is a specific organism which is seen after dog bites. This is seen in the saliva as a normal commensal of the dog's mouth, and then sometimes it can cause serious septicemias. And there are certain post-chicken box findings will show that this is something. The ones marked in black here like this, some of them we have seen. Now this is Leishmanian bodies seen in the peripheral blood. This was a patient with HIV. And this picture has been taken from a slide which was circulated for the Kerala chapter IAPM conference long back, I think in 2006. You can see this. And this is an infection which you are unlikely to see, the Ehrlichia. You see the organisms inside the. It's endemic in USA. It's been increasingly reported. It's a notifiable disease in USA. And incidentally, it's a tick-borne infection. The same tick which transmits the Borrelia of Lyme disease. So that way it's important. Now in malaria, you can see erythrophagocytosis in the neutrophils, in the monocytes. Sometimes these cells do contain the parasites. These red cells will contain, which is why they are actually taken up. So this is also important. This is a parasite inside the RBC, which is actually ingested by the monocyte, and you find malarial pigment. Histoplasma, well, we had the opportunity to see a case of histoplasma recently, and you find that the appearance are similar to Leishmanian, except that you find these crescentic shaped nuclei for that, with a halo-like area, empty space, which actually represents the capsule. This is in contrast to the dot and dash appearance that you see in Leishmaniasis. Otherwise, the size of the two organisms are essentially the same. For that matter, it's a major differential diagnosis. Candida may be seen in disseminated candidiasis. Then meningococci can be seen frequently, but however, we never really get to see it, because most of the time, a patient with meningococcemia never gets to get his or her blood smear examined. Same thing with Clostridia. These are pictures taken from the internet to show you this. But if at all you have a patient with septicemia, meningococcemia, and if you ever get a smear, please look for this, because this is a telltale diagnostic feature. If the pediatrician or the clinician is in a dilemma as to what type of organism produces this, may be the clue. Now, CMV infections, you can get intracytoplasmic inclusions inside, and that can be seen. And you also find atypical lymphocytes in plenty, so much so that CMV is also known as mononucleosis, transfusion mononucleosis, or whatever you want to call it. It produces the same reactive lymphocytes as mononucleosis. Then this is a case which you saw in Trichur Medical College 8 years ago. And this was a patient, post-chickenpox patient, who came with severe anemia. And this is what we saw: ultraphagocytosis by the neutrophils. And this has been described. We thought it was fairly new. When we checked out the literature, it is not uncommon at all. Lots of reports are there. Of course, it's uncommon, but it's been reported several times. So this is one of the things. Now, what are the qualitative disorders of WBC? They're very rare diseases. And the ones which actually show morphological changes and are very obvious are the ones which are marked in black. The others will not generally show any serious morphological changes which can be recognized from the peripheral blood smear. And of which the Chidiac-Higashi syndrome is the most important. Now, this is the Alder-Reilly anomaly. It does not produce serious functional abnormality in the of the leukocytes. However, you find these abnormal-looking granules which represent the accumulated mucopolysaccharides in the cells. And sometimes the lymphocytes also may show vacillation. You can see it in Hurler syndrome, Hunter-Hurler, Sanfilippo syndrome, etc. And these granules are metachromatic, so much so that they will show violetish or reddish stain if you stain it with methylene blue. Now, May-Higlin anomaly is something which is very rare, but sometimes you do see them. I have seen just one case. And here you find the cell neutrophils showing multiple dolly bodies, similar to ribosomal material, similar to what you see in severe infections. However, the important point to remember is that these neutrophils do not show toxic granules. So that is the point. And also you find macrothrombocytopenia, large platelets also. So, and the dolly bodies can be stained with methyl green pyranid. I forgot to mention that earlier. We generally don't do it, but because they are pyronophilic, because they contain lots of RNA. Chidiac-Higashi syndrome is something worth mentioning, because this is a condition which you are likely to see as a postgraduate student. In your 3 years, you will at least see 1 or 2 cases. Now, this is a case, it's a case which I saw when I was working as an assistant professor in Trivandrum long back. That was in 1988. And this is a patient, and this patient actually showed inclusions in the leukocytes also. And these inclusions are large inclusions seen in the neutrophils, monocytes, and lymphocytes, and they represent giant lysosomes. You can see they have a slightly brownish color. So it's, you can recognize that by that color also. And this is a picture of the patient. This is a 4-year-old patient, and this patient had albinism. And one of the things that you can see if you check out the hair in the patient, you'll find that it's containing irregular melanosomes. So much so that it's not properly dark. This is a normal hair. This is my hair actually, dark hair, black, while this is not. So that is one thing. Hypersegmentation of granulocytes. Generally, it's the hereditary form is quite rare, and generally not associated with any specific symptoms. While the macropolycytes or multilobulated cells which you see in megaloblastic anemia are of course symptomatic. Then you have hyposegmentation. Hyposegmentation means that the nucleus, the neutrophil nucleus, is actually having less number of lobes, 2 or even no lobes at all. Now this is a hereditary condition, and the important point to remember is that these may be reported as stab forms, and one will have to look, will have to be conscious that the patients, the cells do not contain toxic granules, because toxic granulation is a feature which you associate with shift to left. So that point you have to remember, patient may be totally asymptomatic, and maybe this may be seen in a routine blood smear. Now you can get this sort of appearance, hyposegmentation, in myelodysplastic syndromes and leukemias. So this is supposed to be one feature of myelodysplasia. So you have to keep this in mind. Now you find multiple drumsticks, think of trisomy, including trisomy X. Now immature cells and neoplastic cells in the peripheral blood smears. We look at different types of cells, carcinoma cells, neuroblastoma cells, melanoma cells. They can all appear in the peripheral blood smear. So very rare, but the presence of carcinoma cells in the blood smear has been actually elucidated, because it is always there, because most of the time it is there, but we don't see it. And this is the reason why we have got what is referred to as a liquid biopsy, where you actually see you take out the genetic material from the cells and identify it to diagnose a tumor, liquid biopsy. So let's see what are the cells. Now this is a leukemoid reaction, and in leukemoid reaction you find up to blasts, you may find even blast cells, but all the other different stages of maturation may be seen. So this is an important point to remember. Leukemoid reaction, you find mature cells along with lots of maturing cells. Now this point is relevant. Now this is a classical chronic myeloid leukemia, where you have this polymorphous appearance with myelocytes, metamyelocytes, blast cells, and invariably larger number of basophils and eosinophils. So this is very typical. Now what is the peripheral blood cell count in leukemia? So for example, acute leukemia, it can be low, it can be normal or high, and there will be a high percentage of blast cells. While chronic leukemias is invariably high. Of course, there are rare exceptions like hairy cell leukemia where you have cytopenia, but generally in chronic leukemias the cell count is high and mature cells predominate, mature or maturing cells. So this point may be kept in mind. Now, if you divide the cells into 3-4 groups, groups, you have immature cells, maturing cells, and mature cells. And if you find mature cells only, it's acute leukemia. If you find immature cells and maturing cells, it's acute leukemia. If you find maturing cells and mature cells, then it's likely to be a chronic leukemia. And if you find immature cells and fully mature cells and no intermediate forms, it's also an acute leukemia. And this phenomenon is known as hiatus leukemicus. Now it's given in the older textbooks. It is no longer used as a diagnostic feature, but still useful to know. Now these are the blast cells that you see in myeloid and lymphatic leukemias, and this is the difference between the lymphoblasts and the normal lymphocytes. As you can see, here you find coarse chromatin with a small nucleoli, while here you find dense coarse chromatin, while the cells are smaller. While myeloid leukemias, you find that the chromatin is fine. This point is important, but of course it's not diagnostic, because rarely you do find lymphatic leukemia with the same fine chromatin. So that can't be. Most of the time, fine chromatin generally means it's myeloid. And of course, you can do the cytochemical stains and you'll find that peroxidase is positive and you can actually make a diagnosis. Now, there are in a leukemia, there are two types of blast cells that may be seen. Excuse me. One is the type 1 blast with no granules at all, and the type 2 blasts which have granules. And sometimes it may even show aurochs. The same thing is applicable for myelodysplastic syndromes also. You may find two types of blast cells. Or sometimes we find numerous aurochs in a blast cell, and this is a characteristic feature of pro-myelocytic leukemia, the hypergranular variant, or you can have the acute promyelocytic leukemia microgranular, which has got the characteristic nuclear appearance, the clefted nucleus, as you can see here, the dumbbell-shaped nucleus. And the granules are fine, and apparently they seem to be agranular. But if you do a peroxide stain on this, you'll find it strongly positive. Now these are the aurochs which are seen in conventional classical acute myeloid leukemia. Sometimes you may find our bodies or large nodular aggregates of granules in the cytoplasm of the blast cells. And now this is a feature which you associate with one specific type of myeloid leukemia, that is AML-M2 variant, and this is called the Chiriac Higashi-like inclusions. So this point may be noted. Now, what are the cytochemical stains that you can do? Personally speaking, I generally do the peroxidase and the alpha-naphthyl acetate ester. These are the two cytochemical stains which are very important, and then you combine it with a PA stain also. These three will give you fairly a decent diagnosis. Now this is a peroxidase stain smear, and you find that the ones marked in black, generally you can't call it a positivity in a blast cell, because it may be a maturing or mature granulocyte. But the ones like this with faint granules in the periphery, you've got to consider them as blast cells with positivity. As you can see here, these are not considered true blasts because there are lots of granules. But you never know, you have to compare it with the morphology also. This is very, very important. The morphology may look like a blast cell, and then you have this positivity, you have to call it a myeloblast. Now you have the monoblasts, diffuse cytoplasmic positivity that you see in the monoblasts in ANA. And also this is a smear which is actually, this is a smear, the picture showing the lymphoblasts which have showing the dot positivity when you do the ANA. So this can be a useful diagnostic feature. The lymphoblast will show, T lymphoblast will show the dot positivity. Now you do the dual esterase in cases of myelomonocytic leukemia. You have the CAE and the ANA combined together, and you give different chromogens for each, and you have the two types of staining. And this is what you see in myelomonocytic leukemia. This is what is called the dual esterase staining. Now the block positivity in cytochemistry is seen in acute lymphatic leukemias, lymphoblasts, and also in leukemic erythroblasts in acute myeloid leukemia, as you can see here. The mature erythroblasts will show more diffuse positivity of the PAS. So this is a very important point you can remember. Now cytoplasmic vacuolation in blast cells can be seen in all types of blast cells. And this is very important, because you can't attribute the vacuolation and say it is this or that. It can occur in all types of blast cells. Monoblasts, acute lymphatic leukemia, AML, conventional AML, AML M1, M2, and acute lymphatic leukemia. And the other point which I want to mention to you earlier regarding the atypical lymphocytes is this. You find large numbers of cells with the skirting and molding, etc., cytoplasm, but all of them have got immature nucleus. You don't find all the other types of atypical lymphocytes, and this is sometimes accompanied by thrombocytopenia. This is a acute leukemia with blast cells with features suggestive of atypical lymphocytes. So this is a point which you need to remember very carefully. So before you sign off a he is saying that they are all atypical lymphocytes. Make sure that you have got the accompanying different types of atypical lymphocytes with them. Otherwise, you may miss a leukemia. Now, lymphoblasts in L3 type got vacuoles which are pH negative and positive for oil red dough because it contains neutral lipid. Now, what are the various types of chronic lymphoid leukemias? Pro-lymphocytic leukemia characteristically has single, even the T cell and the B cell both have single central nucleoli and plenty of cytoplasm. This has lymphocytes, plasmacytoid lymphocytes and plasma cells. So this is a leukemia constituted by lymphoplasmacytic cells, likely lymphoplasmacytoid lymphoma with leukemic spillover. And if you find cells like this, different types of cells, then you have to think of a lymphoma in the peripheral blood, spillover into the peripheral blood. So this, when you find the different types of cells, some of them maturing and mature cell-looking chromatin, got to think of lymphoma. Then you have the SLVL with the villus processes and the hairy cell leukemia with the villus process or villi hairy structures all throughout circumferential. While in SLVL is a short form for splenic lymphoma with villus lymphocytes. You find that may be polar or it may be irregularly in the cytoplasm, seen in cytoplasm. Now these are the cells with cytoplasmic blebs and projections. This is hairy cell leukemia. This is SLVL. Monocytic leukemia with blebs. You have erythroid leukemia, M6 with blebs. Then you have the lymphatic leukemia with the hand mirror-like appearance projections. This is a hand mirror for comparison. In fact, there's a morphological variant. And generally, this sort of morphology occurs in lymphatic leukemias. And then you have the megakaryoblast leukemia. So cytoplasmic blebs need not necessarily mean that it belongs to one type of leukemia. It can be seen in all types of blast cells. The only one close to being specific is the hand mirror cell leukemia. Now these are these are Sézary cells with the convoluted nucleus, as you can see convolutions very clearly, and they may be accompanied by smaller cells. And this was actually a patient who was diagnosed as Sézary syndrome, and the smear sent to us for confirmation. In fact, not Sézary, it was a patient with mycosis fungoides with abnormal cells in the peripheral blood, and the dermatologist sent the peripheral smear to confirm it. And these type of cells are known as butt cells. This may be seen in chronic lymphatic leukemia and also in lymphoma spillover into the peripheral blood. Now these are abnormal looking flower shaped cells and clover leaf cells which are characteristically seen in one specific type of leukemia lymphoma that is known as the adult T cell lymphoma leukemia, which is HCLV1 related. Then you finally have a very rare, this is actually a pictures are taken from the internet, actually Journal of Oncology, melanoma mimicking acute leukemia. You can, carcinomas, melanomas, neuroblastomas can mimic leukemia. In this case, however, that it was telltale pigment was present in the cells, and the bone marrow also was fairly, it looks like a leukemia, all right, but with these cells with pigment. And this is the HMP45 staining showing strong positivity. Now, the last but not the least is the leukocytic reaction. And this is a blood picture where you find immature WBCs, granulocyte series, and plenty of nucleated red cells in the peripheral blood. And this is very common in newborns and infants, but it's uncommon in adults, and when you see it in adults, it generally indicates very serious disease. Now please find out why. Now, there are several studies showing that nucleated red blood cells in the peripheral blood smear actually in a high risk scenario patient indicates high mortality. Fairly old paper, but It's there. There are lots of papers saying that a leukocyte picture in a ICU patient is not good news. Finally, this is a penultimate slide. Now, the pathologist should have or establish a conscious, deliberate, sequential approach when reporting on a blood smear. Then nothing will be missed. Now, keep in mind that the blood smear is always done with the patient's clinical care as a major priority. And to that extent, we have to be careful. Lastly, good communication in the blood smear report is essential in translating the morphological features seen into clinical correlation, which simply means that you got to add the explanatory notes for your findings, because the clinician generally may not have any idea of what some of the things that we write actually mean. So you got to point it out. Some clinicians don't like it, but nevertheless you do it. It's very important that it may be useful to the patient. And this is one of the articles that you can read. You can actually download the PDF file of this. This is very good. It's an open, it's around 140 pages, but shows all the different features. Actually, it's a presentation. So you can actually download this and see it. It's very good. Thank you.